Morning and so today will be the first part of CLL presentation where we'll discuss mostly the basics of CLL, like how you the case of CLL present to you and how do you approach. I will not discuss any clinical trial today. It will be mostly related to the disease biology, diagnosis, differential diagnosis, factors which affects the prognosis, a little bit about vaccination and complications related to disease and complications related to the treatment and the IWCLL, that is International Working Group on CLL guidelines. Okay, so before I start, how many of you know rice staging? Can you raise your hands? Rice staging in CLL. So how many of you know Kanti Rai, Dr. Kanti Rai? So this is an so all of you should know this gentleman, Dr. Kanti Rai, who you can say made that rice staging, and till today this is used in United States, and minute staging is something used in European countries. And I was reading through the history, and I think there is a nice article post in for 3-4 years ago, where there was a full story how Kanti Rai made this rice staging, and he was a pediatrician by practice, and then his observations were very interesting. That he found that some CLL patients were coming daily, every week coming for transfusion. Some are coming say after 6 months, some are coming after a year. So why this variation? And when he asked his professor, the professor told him that the way it is, find out why it is like this. So that's how he discovered this rice staging that you will see subsequently. Okay. Okay, so now coming to the epidemiology, it's the indolent malignancy of mature B cells. Cells of origin is not clearly defined. Yes. So it's indolent malignancy of mature B cells, and the cell of origin is not fully defined, unlike other lymphomas, where it is quite defined now that which are the cell of origin for various lymphomas. Now, incidence across the globe is variable. Now, if you see, CLL is mostly a disease of Western world and mostly the Northern Europe, where the incidence is highest, and the lowest is East Asian countries. Now, it is familial. It is one of the hematologic lymphoid malignancies which has significant familial tendency, and if a family, if a person has CLL, the chances that the subsequent members will develop CLL is almost 8 times. So definitely this is pretty high, but there is no single gene that has been defined that this is the gene. If it is present, then the risk is high. So there are almost 40 to 50 genetic polymorphism that is seen in CLL. So definitely it is multifactorial, but the contribution of genetics is paramount. Now there is something called pre-CLL condition, which is called MBL. That is monoclonal B lymphocytosis. The basic difference between MBL and CLL is the peripheral blood lymphocyte count. If the peripheral blood lymphocyte count is more than 5,000, it is CLL. Less than 5,000, it is MBL. Now, MBL again, it has been classified into low count MBL and high count MBL. So, if it is 2,000 and more, between 2,000 and 5,000, it is high count MBL. So, less than 2,000 is something called as low count MBL. And why it is important to know? Because these patients who have high count MBL, they have similar risk of developing autoimmune complications, similar risk of developing second malignancies. So that is the reason why high count MBL is something which we should know. Presentation, if you see, 80% of the patients present in an asymptomatic fashion, like they are diagnosed incidentally. This is the Western data, and if you see the Indian data from PGI, it is on 45%. So almost 50% of your patients are going to walk to your clinic with a report saying that they were diagnosed incidentally while doing some tests, and they found that the lymphocyte count was high, and that's how they were diagnosed. The rest 50% will present to you with lymphadenopathy, with features of anemia, with constitutional symptoms in the form of weight loss, fatigue, and lastly, autoimmune manifestations. Almost 5 to 10% of patients will present to your OPD with autoimmune manifestations only, and then they were diagnosed as CLL. So autoimmune meaning autoimmune hemolytic anemia, autoimmune say neuropathy like CIDP, you have autoimmune skin manifestation like pemphigus. So the gamuts of autoimmune manifestation can occur in CLL, and that can be the presenting complaint, as I said, in almost 5 to 10%. So now, before I move into the diagnosis and the disease biology, so I thought I will just discuss about something about B cell ontogeny and how the lymphoma genesis occur in B cells. And this will answer a lot of the question that how do you interpret your reports in your flow cytometry, your IHC, and what do you mean by when I say CLL is mutated, unmutated, and many more things of that. So if you see this diagram, so this is the normal B cell lymphoma part, normal B cell ontogeny, right? So when it starts from the marrow, you can see from the marrow, we have stem cells, we have pro B cells, pre B cells, and there is something called naive B cell that comes to the blood first. So naive B cell is something which is not exposed to any antigen, that is just released from the marrow and it goes to the blood. It can be present in the tissue as well. So this is the cell which interact with the antigen first. Any antigen that comes from outside, naive B cell will interact. Now, after the interaction, that naive B cell goes into a lymph node, right? And what is the purpose of lymph node? Lymph node has to give a robust antibody so that that antigen is tackled, and at the same time, it has to give a memory cell so that next time an antigen comes, so we are ready with the memory cell, right? So that is the purpose of the lymph node. So how it does this, how it orchestrates this whole mechanism is something called a germinal center reaction that happens inside the node. So if you see, this is the germinal center at the center, and there is a marginal zone which is surrounding it. The germinal center has two zones. There is a dark zone and there is something called light zone, right? So dark zone is packed with cells. That's why it is dark. And the cells, they are called centroblasts. The light zones are little, the cells are not that much packed as like the dark zone. So there the cells are called centrocytes. Centroblast and centrocyte. So if you see, there are two important things that happen in the germinal center. There is something called somatic hypermutation. Second thing is class switch recombination. SHMCSR, right? So these two particular events determines and gives you that robust immunity against that antigen as well as the memory cell. So if you see the dark zone, there is something called a somatic hypermutation. So what happens is that the cells start proliferating enormously in the dark zone, right? So dark zone is a zone where there's a lot of activity, a lot of proliferation, a lot of apoptosis, so a lot of activities going on. So what is happening is that when there is proliferation, there will be some mutations in each immunoglobulin receptor gene. Each B cell will have an immunoglobulin receptor gene. So that gene has a variable region, and that variable region get mutated. So this somatic hypermutation will create a B cell repertoire, like it will create a different variety of lymphocytes with different kinds of affinity. So that leads to a group of lymph nodes which have high affinity to bind with the antigen and kill it. And another group of lymphocytes which are very low affinity, that is centroblasts, which are very low affinity, they die. So they undergo apoptosis. Now these centroblasts which are having high affinity to bind to the antigen, they go to the light zone. Okay, so they convert into centrocytes, and those centrocytes again selected by two different cells that is called as T cells and your dendritic cells, and they get transferred into plasma cells. So that's a mechanism called class switch recombination. Okay, so the selection is so huge that a very small amount of cells are actually selected. So just think about a civil service examination. A lot of aspirants are giving civil service examination. Think about the dark zone. And your light zone is something which say, the examination proper what is happening, and very few are getting selected. And there are certain situations where some cells are not fit enough, and they are again get sent back to the dark zone to again undergo that process of somatic hypermutation. Same thing, suppose somebody is not selected in civil service, again go back to start preparation, again come back, right? And these follicular dendritic cells and these T cells, they are like the examiners there, sitting there. They will find out which cells, which centrocytes are fit to pass through this and undergo plasma cell or class switch recombination. And then you get two cells, one is memory B cell and plasma cell. Now, plasma cell will start producing antibodies that will take care of the antigen, that memory cell will be there with you, and that will help you the next time when the antigen is encountered. So why I have written three things, CD5, CD10, CD5, and CD10 negative. So if you see B cells, this is the first time the naive B cell where you acquire CD5. Okay. As soon as it goes into the germinal center, it acquires CD10. And when it passes germinal center, they lost both. So you have CD5 and CD10, both are negative. So now, depending on that, where the lymphoma originates, there will be either CD5 positive, there will be either CD10 negative, or there will be negative by both. So if you have this lymphoma which is originating from the naive B cell, so there will be CD10 negative, but the CD5 positive, because they have not entered into the germinal center, right? So what are the lymphomas? CLL and MCL. CLL and mantle cell lymphoma, they originate from the naive B cell. So that's why typically they are 5 positive, 10 negative. CD10 negative is germinal center, so 3 lymphomas originate from germinal center: Burkitt, follicular, and DLB. So all 3 will be CD10 positive, CD5 may or may not be positive. Now CD5 and 10 negative is the rest of the lymphoma which plasmacytic differentiation. So what is that? Lymphoplasmacytic lymphoma, hairy cell leukemia, marginal zone lymphoma. So all these lymphomas will have CD5 and 10 negative because they are originating from a cell beyond germinal center. So they have already lost 5 and 10. That's why they are CD5, CD10 negative. Clear? So CD5 and 10 is most important when you interpret the flow, the ICs for lymphomas. Okay, so I discussed about 5, 10 in detail. So when you see a CLL, typically what you see is peripheral blood lymphocytosis and you send the flow cytometry, right? So what are the differential at that point of time? The differential will be CLL, LPL, MCL, marginal zone, splenic marginal zone, follicular, heavy cell, and BPL. You have gamuts of differentials. So how do you interpret? I will try to simplify it further for you. So you get a sample. First, you do CD19 and CD3. If CD19 is positive, CD3 is positive, it is mostly going towards NKCell lineage. If CD3 is negative, 19 is positive. So 19 is a marker of B cell. So that's why then you start processing for the B cell panel. Okay. So now what do you do? So I discussed just now CD9 positive, CD19 positive, B cell. So now you divide between whether it is 5 and 10. What is happening to 5 and 10? If 5 is positive, 10 is negative, CL and MCL. Now I have highlighted with red, they are the most common situations, right? The ones which are not highlighted in red, you can have variations, you can have certain variations, you can see they're common in some areas also, right? But SCL and MCL are typically 35, 10 positive, 10 positive, 5 negative, I told you, molecular, Burkitt and DLB. Both are positive, you can see again 3, and both are negative, which high cell, marginal and LPL. Now, rarely DLBL, MCL also can be negative, but don't go to the rarer part first. Understand what is there in the red. That is the most common situation. Now, you may have aberrations, and you have to again correlate clinically, but that will not be the chunk of your case. The chunk of your case, you can get it from 5 and 10. Now, this is again a further simplification. How do you go about it? You can keep this slide. So first is CD19. You see light chain restriction. If CD light chain restriction is positive, it is clonal. Okay. And then you divide. As I said, 5 positive. You have 5 positivity, 23 positive is CLL. You confirm by doing a CD200. Now MCL also can be 23 positive. So the only marker that differentiates from CLL and mantle cell is 200. Okay. So you confirm by 200. And from mantle cell, it is cyclin D. If both are negative, you look for 11C. If 11C is positive, then you go to the pathway of hairy cell SNZ. If 11C is negative, so everything is negative now. 5 negative, 10 negative, 11C is negative. So we are left with cell morphology now. Whether it is a large cell, whether it is a small cell, depending on that, you make a diagnosis and also the other things that you see. If it is 103 positive, whether it is 35 positive or negative, it will be hairy cell leukemia or hairy cell variant. Okay. So this is oversimplification of CLPD flow. For all of you, this is enough. Okay. So there will be situations where there will be some aberrations, but again, as I said, that will be dealt with other investigation. Okay. So now the biology of CLL. Okay. So CLL is one of such disease where the disease biology of the malignancy, or I would say the disease biology in the form of the clonal evolution is very, very delineated long time back. Just long time, because the CLL is such a disease which you need to do molecular testing. It is easily accessible. It's a peripheral blood. They are very indolent, slow growing, and you get the tumor purity very well because everything is CLL cells from the peripheral blood. When you do a tissue biopsy, you get diluted with the normal tissue. There are a lot of other impurities. So that's why the molecular technology has been used in CLL, and the clonal evolution is very well determined. So what they found is that there is a situation in CLL where you have clonal equilibrium, right? You have multiple different kinds of clone in a CLL disease, and they are somehow equilibrated with each other, and they are in stable form, right? The second situation is there is clonal competition, right? So when there is a progression of CLL, so one clone compete with the other, right? So that can lead to two situations. When there is a linear evolution, there is a branch evolution. So linear evolution meaning a new mutation coming back and it is replacing the old one. Now branch evolution is the subclone is gaining dominance and it is kind of taking over the dominant clone. So this kind of evolution of CLL is very well depicted. And to give you an example, see this cytogenetic cytogenetic findings at diagnosis and relapse. If you see 13q and trisomy 12 at diagnosis is 50%, and now and trisomy 12 is 20%. If you see the prevalence at relapse, it is same, right? It is not changing. But if you see 17p, 11q, TP53 at diagnosis is 5 to 10%, at progression is 30 to 40%. So that means whenever you are seeing in certain mutations are getting selected at relapse, but certain abnormalities are almost remaining stable. So that's how the concept of a truncal mutation and a branch mutation, right? So 13q and trisomy 12 are like a truncal mutation, the truncal abnormalities. That will persist. But eventually, when the patients progress, they will develop these subclonal mutations that will predominate at relapse. So that's how this clonal evolution is very well and nicely discovered in CLL. So this is a clonal dynamics study done in CLL patients who are weight and right around 100 patients. The cytogenetics and their molecular profiling was done for those patients who are only on weight and loss. They are not having symptoms. To just understand how the growth pattern differs. So if you see, I have given you three graphs, 1, 2, 3. So one graph is showing logistic growth, like the growth is gradually happening and then there is a flattening. Okay. The third one is exponential growth. The growth is quite rapid and fast. And the third one is intermittent, somewhere in between. So these three different patterns of growth are seen in CLL. Those are weight and growth. They are not having any symptoms. So that means you will have progression of CLL, but at some point of time they stabilize. There is some variations. And another group, there is progression ongoing, right? Continuously, there is exponential growth. So what is the difference between the two groups? When they looked at the mutational pattern, they found that those who are having exponential growth, they are likely unmutated one. This is the red one you can see. And they are mostly having a lot of mutations. And if you see the group which is having logistic growth, there is hardly any mutation. You see the mutation is very less. So the genetic stability is good. They're unstable. They're not unstable. Unlike the unmutated ones, they're genetically unstable. A lot of mutations. And there is rapid proliferation, right? So why this is important to understand is that when you see the CLL patient in OPD, this is there is a 13q, right? So 13q will be mutated and there will be a gradual growth and there may be flattening. So we have to be patient. You should not jump into that. Okay, this patient is progressing. I do something. So that's how the disease biology is depending on the what mutation they carry. Now there is another aspect of CLL is about the microenvironment. Now all of you know about microenvironment is very important in solid tumors and various diseases also. So now one of the good theory of microenvironment role in CLL is very well established inside the node. So what is happening inside the node? So what happens is that when you take out the CLL cell from the blood or from the node and keep it outside, they die. Okay. So this is true for many malignant cells also. So you need a stimulus from the microenvironment to keep them alive, right? But they don't get that stimulus inside the blood. So what happens is that the CLL cells have this trafficking from the fetal blood to the node and again to the blood. So they like roam around, right? So what is the purpose is that when they go into the node, they get the stimulus from the microenvironment. And that keeps them alive. That prevents them from apoptosis, that prevents them from dying. So if you give an example of pit stop in the Formula One race, what happens? You have pit stops, there are the Formula car or the cars are racing, and then suddenly they're stopping a pit stop and they're refueling, reservicing again. So these nodes act like a pit stop for CLL cells. So how they get the stimulus? From two different cells. One is follicular dendritic cells and nurse-like cells. Okay, they release the CXCL12 cytokines which attract those cells and help in giving those stimulus. And what are the stimulus? Very interesting names, BAF and EPRIN. Remember, you just remember the name, you'll understand, and when you read about the biology, you'll know it better. So these are the acronyms for the stimulus that these nurse-like cells release. Second interesting thing happens, anti-apoptosis, right? So why the CLL cells do not die? Because of their strong anti-apoptotic signal, and that is because of pro-survival signals from BCL2 and MCL1. Okay, so what happens when you give ibrutinib? So interestingly, ibrutinib stop this pit stop. That is one way that it helps in killing. So it doesn't allow the cells to go into the node and get that stimulus. So when the cells will be in the periphery, in the peripheral blood, they will not get those stimulus and they die. Or else you can add some agent with ibrutinib and that will kill. So fascinating biology that you give ibrutinib, you stop the trafficking, and then you add another agent to ibrutinib, and that takes care of the cell, and they don't have any backing of those microenvironment, and they die subsequently. So that's how the treatment of CLL has evolved in terms of the biology. Okay. Okay. So now prognostic factors, Wright and Binet staging we discussed. So this is the Wright staging 0, 1, 2, 3, 4. There is no 5 in Wright staging. So first is 0. Right? Just remember this. It starts with 0. It doesn't start with 1. So 0 meaning only lymphocytosis. 1 meaning you have lymphadenopathy. 3 meaning you have hemoglobin less than 11, and 4 meaning when the platelet is less than 1 line. So sometimes we may find that some patient doesn't have a node, right? Doesn't have organomegaly, but platelet is 94,000. Okay. So is it like 4? So unlikely. So we have a situation. Typically, what happens is that this kind of stage 0, 1, 2, 3, morely the patients develop node, then organomegaly, then develop thrombocytopenia. This is somehow kind of incremental way of prognosis. It's not like that somebody will have stage 0 and have low platelet. So we have to find out why the platelet is low. And sometimes the platelet is low because of their ethnicity, because of some other reasons, right? So you should not look for that. A CLL patient is only platelet 94,000. No nodal enlargement, no organomegaly. I will say CLL stage 2. That's not true. Okay, so just keep in mind. Similarly, Binet based on the lymph node areas, and Binet is mostly used in European countries, and rice is used in US countries, right? Now, what are the factors and what are the significance? So 17p, TP53, I will discuss in little bit detail. So Notch1, 49D, IgG mutation, complex stereotype. So these are well established factors which tells you the significance of each, right? I'm not going in detail. So as I said, in 1975, you have rice staging, Binet staging. Then most latest, I would say CLL IPI that came in 2016, right? So CLL IPI is based on age, clinical stage, beta 2, 17p, IgVH status. Okay, so we have 5 factors which determines those divide the CLL into 4 categories, right? Low, intermediate, high, and very high. So what is the purpose of this CLL IPI? It will tell you that when the patient will require the first treatment. That means patient is asymptomatic, you did a CLL IPI, the CLL IPI is very high. That means this patient will require treatment in next 5 minutes. That is CLL IPI. If the CLL IPI is very low, this patient will require maybe after 2 years or 3 years, we don't know. So you remember that the growth pattern that I have shown. One is exponential, one is in that logistic growth. So this CLL IPI will tell you whether this patient is going to have a logistic growth or have exponential. So what is the significance? Today a patient comes to me, the CLL IPI is low. And rest assured that this patient is not going to need treatment in next 2 years. I can call the patient after 6 months. No, enjoy your life. Don't call the patient every 3 months and do blood test. If you have a CLL IPI is very high, you need that this patient is going to need treatment. You should have low threshold to start the treatment for this group of patients. Yeah. So that in that way it will help you. The PGI group has kind of invented, I can say, CLL LIPI, LIPI. So IgVH mutation is usually difficult to do. Many centers don't do. So what they did, they replaced the IgVH mutation with lymphocyte doubling, and they made it CLL LIPI. There is a paper published 2 years ago. I have given the reference. You can read that. And now cytogenetics, we have FIS and conventional. Now FIS is easy to do in CLL. Conventional is very difficult to do because CLL cells are very indolent and they are not dividing very fast. No? There are very few patients are actually in the cell cycle. So you need metaphages to do conventional. So CLL cytogenetics, which is conventional, is very difficult to do. They typically do stimulated conventional. That means they have to stimulate the cell to divide and then do the conventional, right? This is difficult to do. I will discuss a bit about it, but it is not routinely done in any center. It has prognostic significance, and that's it. It doesn't tell you beyond that. And there is still controversy in that. Now, IgVH mutation is something which everybody does. We do in our institute. Molecular testing we do, TP53, not one, we don't. Okay. So this is cytogenetics. Okay. Now cytogenetics I have enumerated. So the first time this concept came in 2000, it's an Anidon paper from Donor. There's an interesting paper. It's the first time cytogenetically divided into 5 different groups. So 4 cytogenetic abnormalities are very common in CLL. 11q, 12, the trisomy 12, 13q, and 17q, right? And switch is no cytogenetic abnormality. So this is 5 groups. Easy to remember, 11, 12, 13, 17, right? There is no 14, that's all. So how do you say which is good, bad? If it is 13q, it is I would say good. Okay. If it is trisomy 12, it is somewhere in between. 11 and 17 is bad. Okay. Don't kind of exchange with, So 11q and 17 is bad. 13 is good performance. Okay. Now, this is the graph that I have shown you is from the ERIC CLL network, where they have done the conventional cytogenetics, the so-called stimulated conventional cytogenetics, and found out what is the relevance of it. So they have divided the cytogenic abnormality into 3, 5 or more, 3 or more. Depending on that, they have made the names like complex stereotype, low complex stereotype, high complex stereotype. So it has its significance only in prognosis. If somebody asks after the class, I can explain it, but I'm not going in detail now. Just remember that it is difficult to not do routine. It's only prognostic. Now, TP53, you should all remember in CLL. That's important for everybody to understand how the evolution of TP53 abnormality happened in CLL. As I said, in 2000 was the first paper from donor hierarchy model. That was the first time TP53 people knew that 17p abnormality exists and they are very bad in CLL. Subsequently, they found that there is something called TP53 mutation also, but they are not, supplementary to each other. That means there can be situations where 17p will be absent, but TP53 can be present, right? And there will be situations when both are present. So that means the significance of that is that you have to do both. You can't just do 17p and say, Okay, so TP53 will be negative. So we have two alleles. So one allele can be lost, one can be mutated. So that's why in ERIC, if you see 2018, they added that in the recommendation that you have to do both. And both meaning Sanger sequencing for TP53 mutation and FISH that is related to 17p. Now, with the advent of NGS, so now can you detect more TP53? Yes. So what happens is that when you do NGS, it is more sensitive, right? So then you can detect TP53, which are present in a very subclonal way. Remember the subclonal concept of CLL I told you? There may be situations where the CLL TP53 clone is small and minor. That NGS can detect, right? So what is the significance of that? I'll come subsequently. So then you will understand what is significance in the NGS. But broadly, if you see 70% will be wild. If you do by Sanger, it is 14. And if you do by NGS, you can pick up 16% more if you do by NGS. So that means NGS will pick up more TP53 clones, those who are in the form of subclone, or typically what happens is that when your NGS VAP is 10% or more, that correlates with the Sanger positivity, right? So if your VAP is 10% and high, that denotes that it will be also positive by Sanger. So most of the data of TP53 came from the Sanger data, right? The data of use of targeted drugs, chemotherapy, everything came from Sanger. So now we have got NGS. So we are doing NGS. So obviously we can pick up those clones also, which are VAP less than 10% also, right? So what is the significance of that 1 to 10% VAP TP53 is still unknown. There are data either way. There are data saying that if you have a very low clone TP53, they are still bad. If you have low TP53 clone, it is not bad. It is as good as having wild type. So there are conflicting data, and Eric has clearly mentioned that 1 to 10% you just have to report what the clinician will do, that they will decide. It is just a caution, right? So why it is important? So why it is important to know that you have TP53 sub clone, whether you have clone, because you have drugs now, right? Ibrutinib is there and that is generic, right? And now the cost has come down. So now this debate will emerge again that whether we should look for those subclonal TP53 where you prefer ibrutinib over a chemotherapy, right? So when we will discuss about which is better in treatment part, you'll understand that the CLL landscape has significantly changed in last 2000, no, last 4 years, where if you see the NICE guidelines, they have almost omitted chemotherapy now. So I think every patient should receive targeted drugs. That's what is the and a very huge select group of patients now chemotherapy remains as compared as by the NICE. So that's why you have to understand TP53, even it is subclonal, you need to detect, you need to have a test with better sensitivity. So this is the ERIC standing, as I said, the recommended threshold for reporting is 10% for 1 to 10% with donor. Prospective clinical trials have used Sanger for TP53. Now, after TP53, the second big prognostic factor is IgG mutation. So what is IgG mutation is, you remember now the ontogeny slide that I have shown, what is mutation? The mutation that happens in the germinal center is that IgG mutation we're talking about here, right? So what happens in the germinal center? The cells which are dividing, they undergo this somatic hypermutation, right? So this is the immunoglobulin gene, the constant region, the variable region, and VH is variable heavy and VL is variable light. So these are the VH region undergo this mutation, right? So now how do you know that they are mutated or unmutated? Depending on the amount of mutation that they undergo. So how do you compare? So you have to have a comparator that whether they are mutated or not. So you have a germline comparator. So you compare with the germline in the patient sample. You have a germline comparator and you compare the patient sample and see how much is the difference in terms of mutation. If the mutation rate is 2% or more, then that is called as mutated. If the mutation rate is less than 2%, it is called unmutated. Okay, that's how the difference is. And you know how significant it is. If you see the era in the chemotherapy, the difference of outcome between mutated and unmutated is huge. The median survival is 3 to 10 years. There are various data, I just clubbed it together, so 3 to 10 years. When you see mutated, the survival is 17 to 25 years. So we are talking about two different disease now, right? With a phenomenally different outcome if you just know whether they are mutated or unmutated. Okay, so why IgG unmutated is bad? Because as I said, the cells are rapidly dividing, they are the exponential growth. So that's why they are bad and they also are bad. So what is the percentage of mutation that we see in routine clinical practice? Almost 2/3 of your patients will have unmutated CLL. Only 1/3 will have a mutated type of IgG. There is something called B cell stereotypy, which is coming new. A lot of controversy on that also. So what happens is that 30% of CLL have common B cell receptor alleles. So there are certain alleles which are bad, even if they are mutated. So as I said, mutated is good. But in certain group of mutated, when they have a special B cell receptor allele, they behave like unmutated. So that is called a subset two. There is a subset, they have different subsets. Subset two is bad, but again, as I said that these are all very recommendations. They are not used clinically. Clinically, the use is CP53 NGS or Sanger and IgG mutation. So we need these two information for all our patients to know about prognosis and to plan the treatment. Just to give an example, so this is a 42-year male presented with EG fatigability and cervical node for 5 months. Clinically, he had cervical nodes, 4 centimeters splenomegaly. And when we did the investigations, hemoglobin was 8, TLC was 1.6 lakh, 90,000 platelet, Coombs was negative, and 13 Q was deleted. Now, what do you do? As I said, TP53 and IgG mutated. Okay. So this is the report of that patient. If you see the thing highlighted in the red, the second one, CLL IgG mutation status mutated. And if you see what they have written, so following 98% germline identity, cutoff value is this used for discriminating CLL cases is 2%. So what is the mutation in this patient? 92%. Right? So there is 92% synergy with the germline. That means 8% are mutated. So as I said, more than 2% is mutated, right? So this is mutated. So that's how we repeat a report of IgG mutation. You see what is the kind of homology with the germline mutation. If the germline mutation is say more than 98%, then definitely it is mutated. Less than 98%, it is unmutated. Now TP53 again the same report you can see that it is pathogenic, but you see the VAC 2.75. So you get these reports. This is a very patient which is unusual and this is rare. But I have given this to show you that how to interpret the report. As I said, when you have a TP53 more than 10% by NGS is significant. Now less than 10%, it is subclonal, the significance of it unknown. But by and large, as I said, TP53 Sanger and IgG mutation is something to be done in all. This is an outward report. I don't want to discuss more about that. And this is some data of subclonal TP53 also showing same bad outcome as clonal TP53. So in that way, we have to know this information when you treat patients in the clinic. Now I will discuss about IWCLL guidelines. So International Working Group of CLL is an international body where they make the indications or they make those guidelines, which patient to be treated, how to assess the response, so all of that. They don't give treatment, what treatment to be given, but they give which patients should be treated and what investigation you should do before you treat the patient. So these are the recommendations for IWCLL. You can see that for all patients, you have the basics, that is test to establish the diagnosis, assessment before treatment. Now, what are the additional tests they have recommended? So molecular cytogenetics fixed in always. If it is general practice, it is always. Conventional karyotype, as I said, the stimulated one is not usually required in clinical practice, but you can do in clinical trial. TP53 mutation always, IgG mutation always. Now CT scan depending on whether the patient needs the treatment or not. Now, treatment indication is important. So you remember, as I said, that the dose of CLL clones or weight and watch group is different. There are some group of patients which are progressing faster. There are some group of patients which are somehow kind of stable in the group. So what are the indications of treatment? Any evidence of progressive marrow failure. So any patient developing anemia and thrombocytopenia, less than 10, less than 1 lakh. However, as I said, platelet count less than 1 lakh can remain low for some patients. Massive splenomegaly, 60 centimeter or more. Massive node. Any node more than 10 centimeter in size, and progressive lymphocytosis, that is lymphocyte doubling count of less than 6 months. So you count the lymphocyte ALC counts in your CBC report, and you see that whether they are multiplying or doubling every 6 months or not. And before that, you rule out other causes like infections or use of steroids, and also they should have a lymphocyte count of more than 30,000. That means it's not like somebody has a 10,000 lymphocyte count and now it is 20. So it is not kind of satisfy this criteria. This should have at least a baseline ALC count of more than 30. Autoimmune complications like anemia and thrombocytopenia, as I said, that almost 5 to 10% can present with only autoimmune manifestations, and you treat them according to their autoimmune disease. I will discuss that. So if they are not responding to their conventional treatment for autoimmune complication, you treat them, and you have symptomatic and functional external involvement and disease symptoms, the conventional B symptoms like weight loss, fatigue. So response assessment is again by doing a repeated scan, blood counts, and constitutional symptoms, and whether your hemoglobin, platelet, and TLC has improved or not. Based on that, this is the response. So now I will discuss about disease-related complications in CLL. So disease complications mostly I'll focus on autoimmune and risk transformation. So 5 to 10% of CLL can present with autoimmune hemolytic anemia, and most of the common is IgG type, that is warm hemolytic anemia. Rarely you can get cold agglutinin disease, which is mostly IgM driven. Hypogammaglobulinemia is seen almost 25% patients. In my clinic, Mayo Clinic data, 25% again develop further, but again this percentage may vary depending on what is the cutoff that they have used. If you use the cutoff of 600, whether you have used the cutoff of 400, but by and large, pretty good number of patients do have hypogammaglobulinemia, and you should check the hemoglobin levels, IgG levels when they come to you, because these patients are definitely prone to develop recurrent infection, and they do improve if you just replace them with immunoglobulins. Now, ITP can be seen in 1 to 5% patients. ITP plus AIHA can be seen in very few group of patients called Ivan syndrome. Now, rarely there are certain autoimmune complications which are pretty rare, but we have seen a couple of cases. We have one case which is with a lady with an angioedema. No, that's all is the presentation. That's how she presented into diagnosed ALL. So CLL. Bullous pemphigoid. So they can present just like the way in the skin OPD somebody presenting pemphigus vulgaris, nephrotic syndrome, CIDP. So these are complications which are rare, but you will see in your clinical practice. So how do you approach this group of patients? First, you see that whether these patients meet the IWCL criteria or not. So are they listed before? If they meet the IWCL criteria, they need treatment for CLL, right? If they do not meet the IWCL criteria, they just have autoimmune complications, so they just need steroids or immunosuppression. So depending on what kind of, mostly it is steroids everywhere, except if it is a cold agglutinin disease, steroid doesn't help. There you have to use rituximab or bendamustine. As I said, typically how you treat this patient, start with prednisolone 1 milligram per kilo, give for a month, and then taper. Slow taper is important. You should not just stop and taper fast over 2 weeks and then think that autoimmune. So they have tendency to recur, right? So the tapering has to be gradual. And if they develop steroid refractoriness, there is some contraindication to use steroid. You can use rituximab as well with 70% responses. As I said, cold agglutinin disease is still ineffective. Now, ITP is important. Few of the patients will present, and how do you diagnose them? Their history will be very short, acute onset. Within less than 2 weeks time, and severe thrombocytopenia, like 10,000-12,000 of platelet having petition purpura. Another group of patients will have thrombocytopenia, but as I said, 70,000-80,000, and they'll be going on for long. So these are not the classical way the ITPs are. So then you have to find other causes in those group of patients. So ITP is pretty clear in terms of the presentation. The third is PRC, that is pure erythroid aplasia. Again, only anemia. You don't have thrombocytopenia. You don't have any other feature, and you diagnose it by doing a bone marrow and see the erythroid group, and if it is completely absent, then it is a PRCA, and you have to rule out CME and parvo in this group of patients. These are common makers, and then use treatment is steroid and cyclosporine. But important to know about PRCA is that they don't respond very fast as we see in AIHA. Their treatment is slow. There is a lag time in the way they respond, right? So we have to have patience when treating this group of patients. The Richard transformation is something which is transformation to an aggressive lymphoma arising from a background of CLL. So CLL is an indolent lymphoma. So from that, when there is an aggressive transformation to a high grade, that is called Richard transformation. So you typically how the patients present, they present with a node enlarging rapidly as compared to the other node. They can present with fever, high LDH. So these are the way they present, and the incidence is 2 to 10% over the entire course of CLL, and 1% per CLL patient per year. Now, if you see the histopathology of Richard transformation, almost 90% will be diffuse large B-cell lymphoma, 10% can be Hodgkin, and 1% can be histopathologic sarcoma. So rarely we have seen that those cases also where there is histopathologic sarcoma as a transformation. So important is there is something called clonally related or unrelated. So if the transformation is related clonally with the CLL, then they do pretty bad. Their outcome is 8 to 12 months. Whatever you do, the median survival of Richard transformation is 8 to 12 months, and most are clonally related. There is a very few group of patients who are clonally unrelated. They may do well, and their outcomes are more or less similar to what you see in de novo DLB. But as I said, there is a very small group of patients. Most of the patients will be clonally related, and their outcome is bad, right? How do you treat? So there is a nice PSS good practice paper, because when you don't have evidence in something, you see this nice good practice paper from BSS coming. There are a lot of situations you see this good practice paper. So this is a consensus recommendation guideline, you can say that. So typically these patients should be treated like R-CHOP, like kind of regimen, but the decision about transplant you have to take based on their fitness, based on the presence of TP53, and based on the response to chemotherapy, right? So it is good if the patients are fit and they have a mass sibling donor, they should go for transplant. Now, auto versus allo, there are data from the EMT group, pretty similar. Both the relapse rates are quite high if you do auto. Allo, again, the risk of treatment mortality is high. So somewhere between 30 to 60% is the outcome if you see from the EMT data. But if the patients, the response to chemotherapy is not good, they are typically mutated, they are clonally related, they should undergo something beyond chemotherapy because they are not going to do well, right? So these are the garden variety of future transformation that you will see clinically. Now, vaccination is something which is important in CLL. Most of you know that CLL is immunocompromised state, and whenever you give vaccines, the vaccine response is not as good as other diseases. No, so that's why they need more doses of vaccine. Influenza vaccine, 2 doses boost every year. Pneumococcal vaccine, usually they are very much, the immune response is not good for polysaccharide vaccine, so we have to give both polysaccharide and conjugate vaccines for pneumococcal, H influenza, single dose. Now, COVID, 3 doses followed by booster after 3 months. And important is no live vaccine. We should not receive any live vaccine, be it MMR, be it Varicella zoster. You should not give any live vaccine to CLL patients. They should receive dead vaccine or the conjugate vaccine or the polysaccharide vaccine. Right? So this is something which is nowadays you have COVID, and vaccination, COVID vaccination in CLL. So this is a recent paper published in Cell Press. What they found, they have looked at seroconversion rates and they compared with the normal healthy individuals based on the number of vaccination. And what they found is that 20% will never develop seroconversion in CLL. Now, if you give 3 doses of COVID vaccine, the after third dose, fourth dose, there is no further increase, right? Up to third dose, there is an increase. And if you give beyond third dose, like fourth dose, there is no increase in the seroconversion rate. So they have concluded somehow that, probably 3 doses typically is important, and then you give boosters, right? So that means they need one additional dose as compared to the healthy individual. Even JCPA also recommends third dose as a primary dose, and then you give booster every 3 months, and they have recommended preferably mRNA vaccine. Now, coming to the novel agent, so I discussed about the disease-related complications, and now I'm switching here to treatment-related complications, right? So now, in the last 3 to 4 years, as I said, that there is 3 novel therapy that has come in the CLL field, and we have only chemotherapy. Now it is ibrutinib, venetoclax, and obinutuzumab, which is typical for 3 musketeers, and this is the new phase 2 data that has come up combining all three, and probably the combination of all three is better. So we will discuss that when we discuss the treatment. But what I will discuss is a bit about these drugs and how do you handle and what are the toxicity that you see. So BTK inhibitor is Bruton's tyrosine kinase inhibitor. All of you know what is Bruton's. Bruton's A gamma globulinemia. It was after a colonel named Bruton, and this photo, and this was the first paper he published. He found some children without any immunoglobulin. This is a membrane of that paper. So this is B cell receptor signaling. So why you have to understand this? To understand the mechanism how BTK inhibitors help, you have to understand how B cell receptor functions. So if you see BCR is B cell receptor, they encounter an antigen, and then that subsequently activates something called signalosome. So it leads to formation of a signalosome by combination of SYK, SIG, LIN, and CD79B. So altogether, this signalosome will activate with carbo B and your PI3K pathway, and that leads to proliferation. So based on that, so there is something called BTK there you can see, and this is also a tyrosine kinase which helps in activity of the signalosome. So BTK inhibitor, what it does, it inhibits that Bruton tyrosine kinase and prevent those downstream activities. And microenvironment is something, as I discussed previously also, the microenvironment plays a significant role in the CLL pathogenesis. I'm not going into details now. So typically you have 4 BTK inhibitors. You have ibrutinib, acalabrutinib, janubrutinib, and pirtobrutinib. If you see the basic difference of BTK, ITK, and TAC, so these are all tyrosine kinases. So what we are interested in is BTK, right? So ITK is interleukin-2 mediated kinase, TAC is something which tyrosine kinase in HCC, that's how the name is. So these are all off target. We don't need the activity in those kinases. Okay, we need targeted activity in the BTK. If you have the activity in the ITK and TAC, you will have toxicities, and that's what we see in ibrutinib complications, right? So if you see as you go by, and these values are IC50s, the IC50 of that for that receptor. So if you see the IC50s are quite high for ITK and TAC, if you keep it a good. So as you go in higher generation of BTK inhibitor, their selectivity to the BTK is very good, and the off-target activities are less. Okay, so I will discuss that how this is important. When you have ITK and TAC activity, you have a lot of fibrillation. If you have more TAC activity, you have a lot of bleeding. So why that is less with acylabrutinib? Why that is less with pirtobrutinib? It is because of these functions that they don't inhibit ITK and TEC. Now, ibrutinib toxicity is fibrillation, bleeding, infection, ataxia. So commonly, if you have to tell what the three important toxicity ibrutinib, it is fibrillation, bleeding, and infections. And this is a nice data of all studies done in ibrutinib space, and they have combined all the toxicities that you see. And if you see, the toxicity is also vary based on how much, depending which year of treatment you are. So there are certain toxicities which improves as you kind of continue the drug. Like you see diarrhea percent. You see 0 to 1 year, it is pretty high, almost 40 to 50%. And after that, after 1 and 2 years and 2 to 3 years, the percentage goes down. So most of the toxicities, the incidence goes down as the patient keep on taking the drug. But there are certain toxicity, like you see, if you add hypertension, you see as the age increases, the hypertension kind of increase. If the patient takes 2 years, 3 years of treatment, then the amount of new hypertension will be high. Almost 30 to 40% will be hypertension. So you have to keep in mind that if the patient of taking ibrutinib coming after 2 years, the chances that will be hypertension very high. So you have to be more vigilant in checking the blood pressure. Why it is important? Again, that will lead to something called as cardiovascular outcomes, that will lead to that fibrillation. So everything is connected like that. So this is important to understand how the toxicities behave based on the years of use of ibrutinib. So I have given this, these are nice cartoons, how ibrutinib induced atrial fibrillation occur and how ibrutinib is bleeding out. So I told you about TEC. So when ibrutinib inhibits TEC, it inhibits the PI3K pathway. So PI3K pathway is important to maintain the electrical equilibrium of our heart muscles. Once PI3 kinase or PI3 pathway is hampered, any kind of stress can lead to atrial fibrillation. So that is the reason why ibrutinib causes atrial fibrillation. Bleeding again is inhibition of TEC. 7 to 10% patients in the initial randomized studies that were done in ibrutinib, they have reported atrial fibrillation. But if you see the real world data, it is high. So if you compare the ibrutinib cardiac outcomes or cardiac complications with the trial data, it is definitely scary to see that. If you see the real world data, it is 50 people are up to 30 to 40% also, right? Obviously, this happens because if you see the trial data, it will be highly selected group of patients. If you use ibrutinib in the real world, you use patients who may have some kind of cardiac comorbidities, hypertensive, diabetics, obese patients. So they all have risk to develop atrial fibrillation. So that's why if you see the real world data, the atrial fibrillation is pretty high, right? The incidence is most in the first year of therapy. And I told you why this atrial fibrillation occurs because of PI3 kinase. Now, atrial fibrillation leads to a trial, right? If you have atrial fibrillation, you have this from cardioembolic event, you will get anticoagulation leads to bleeding, and ibrutinib still will cause bleeding, right? So this is a trial. So once there is atrial fibrillation, patient go into the deadly trial of fibrillation, anticoagulation, bleeding, again ibrutinib. So that's trial continues, right? So what do you do? How to manage that? So there is no data that if you stop ibrutinib, atrial fibrillation stops, right? So that's how it is. So once there is atrial fibrillation, it very few will revert, but most will not be revert. So it is going to stay with that, right? So now you have to see what is the good old medicine teaching that you control the right? There is no study which has shown that rhythm control is better than rate control in atrial fibrillation. In studies in cardiology. So that's how you control the rate, and you decide whether you need the patient with anticoagulation. So and you based on your CHAD score, if it is 2 or more, the patients need anticoagulation. So now, if the patient has instability, atrial fibrillation, high heart rate, unstable patient, heart fibrillation with heart rate of 150, unstable, that is the situation you have to stop, right? Till the heart rate stabilize, till the patient is stable. Typically, what we do, stop ibrutinib if the patient has instability, send to cardiologist, let cardiologist decide whether the patient needs rhythm control or rate control. And typically, they use beta blockers, right? CCBs are contraindicated. They have serious interaction with ibrutinib. So beta blockers, and they will decide whether you need patient need anticoagulation or not based on their risk versus benefit assessment, CHAD score. And when the patient come back to you, then you decide whether you want to continue with me. Suppose the gut guy has started warfarin, right? Obviously, you can't continue with me because it has serious interaction. That's what you need the discussion with your cardiologist. What is his plan of anticoagulation and rate control, and that will tell you what you want to do the everything. So, correct the matter is that not that you stop ibrutinib with the patient I was sick type. No, it is not going to revert. You have to think about disease and how to go about it, right? There are case reports of ventricular arrhythmia and sudden cardiac death also. So definitely it is something which is concerning. Now coming to bleeding, right? If you see predominantly the bleeding is minor, ecchymosis and petechiae. You don't see major bleeding like SDH, bleeding from the lung, hematuria. Of course they are there, but I have shown you those percentages there. But if you see, mostly they are minor bleedings. Okay. So now again, bleeding, and you have antiplatelet, anticoagulation, and you have AF. So everything is, as I said, this triad will continue with the patient. So you need that discussion with the cardiologist. So whether the patient has, so what is the data? If you are using antiplatelets or anticoagulation with ibrutinib, there is bleeding risk, but it is acceptable. But if the patient is either on double antiplatelet or one antiplatelet, one anticoagulant, then the bleeding risk is pretty high. Right. So typical situation is a patient is coming, with an MI, and the cardiologist want to put, drug eating stent. So he will have to continue with antiplatelet for a pretty long time, right? So you can't give it there. But somebody is using a bare metal stent, one antiplatelet for 1 month, or two antiplatelets for 1 month, and then shift to one antiplatelet. So you need that discussion with your cardiologist. What is his plan of anticoagulation for the stent? And then you decide about your BTK, whether you want to go about it, what is the bleeding risk. So all these things are important when you take decisions about using the drug, continuing the drug. Better drug is definitely acalabrutinib. I'll come to that. So how to manage this bleeding things? So you have to avoid drugs. Now important is the patients who take other drugs which are antiplatelet activity. So if the patient is already on antiplatelet and ibrutinib, and suppose that guy is taking some fish oil, vitamin E, they have minor antiplatelet activity, but they will add to that insult. Okay. So typically they say that ibrutinib 420 is equivalent to 150 milligrams of aspirin. That is the kind of antiplatelet activity it has. So think about adding more drugs with antiplatelet activity to just add to the insult. So you have to see whether the patient is taking any alternative medicine, such as fish oil, which is vitamin E, or curcumin for that matter, also a mild antiplatelet activity. So that can aggravate this bleeding. So that you have to see in your drug chart for the patients. So as I said, antiplatelet, either one, avoid dual. Okay. No data for lower dose. If you go down the dose of ibrutinib, everything bleeding is less. There is no such data. Pre-op, important. As I said, bleeding is high. So if you are planning a minor procedure, stop ibrutinib 3 days before. If it is a major procedure, stop 7 days before. Right? It has significant antiplatelet activity. Only bruising, you can continue ibrutinib. Infections are a concern in CLL per se, and ibrutinib also leads to immunosuppression and more infection, almost 50%. And the reason being, not only is completely related to ibrutinib, it is also because of the disease. Because when you start treatment of CLL with ibrutinib, the patients, the disease is just diagnosed, and they have their immune dysfunction is quite new, right? To settle it, it will take time. So during that time, if you have a drug which itself has immunosuppressing property, it will add to that insult, and the infection complication rates are high. Typically, what you see, most infections are in the first 1 year. After 1 year, if you see, the infection rates are less. Why? Because by the time the patient receives 1 year of ibrutinib, they somehow their disease is controlled. Their the T cells, their immunoglobulins are now in normal state, so now they can tolerate any kind of infection. Whether you need any kind of prophylaxis, PCP prophylaxis is not usually required. Antifungal prophylaxis is definitely not needed. How to manage if you have grade 3, grade 4 infection? Stop ibrutinib, check immunoglobulin levels. Don't re-challenge definitely after this life-threatening fungal infection. Vaccinate all your patients before you start ibrutinib because it is important. There will be more infection. PCP prophylaxis you can consider if the patient has a relapsed refractory setting because their immune suppression is definitely high. Other less complicated hypertension now increase over time, unlike other toxicity, need good control of hypertension to prevent an AF. Diarrhea typically because of EGFR property they have diarrhea, so that you can use by giving anti-morbidity drug. Arthralgia sometimes can be worrisome, so there you have to use drugs like SSRIs, magnesium supplementation. Skin drugs is not a significant complication. Now next drug is venetoclax. So after ibrutinib, now second important drug in CLL is venetoclax. The mechanism of action of venetoclax is quite interesting. So there is always a fight between BCL2 and BAC. There is an equilibrium, between them. So BCL2 is anti-apoptotic and BAC is pro-apoptotic, right? So typically what happens, there the natural ligand for the receptor is BH3, right? So when the BH3 is attached, BAC is closed. What venetoclax does, it sways the balance in favor of BCL2. That means it is BH3 mimetic. It will attach to the BCL3, and when it attaches, it releases. You can see it attaches to BH3, and it will not allow the ligands to bind to the receptor, and subsequently your BAC will be activated, and that leads to apoptosis. So that's how BACs and BCL2 is interconnected, and BCL2 somehow kind of sway that balance, and so that you have more apoptosis. So simple, in simple term, you have to remember that there is always this pro-apoptotic and apoptotic are simultaneously interlock with each other. BCL2 sway that balance so that your apoptotic pathways take over and there will be apoptosis. That's what BCL2 acts. Important thing is how fast this venetoclax can act. So this is the phase 1 data of venetoclax. You see one drug given at pre-drug ALC count, and you see within 8 hours the lymphocyte count crashes like anything. 8 hours. You can imagine a drug which is oral given within 8 hours the ALC count crashes. LDH goes up. So it is such a fast acting and effective drug. So what is the implication? You get hemolysis fast. You have to check your hemolysis parameters. Next parameter should be after 8 hours, that means, right? And why this? That's exactly the concept of dose ramp up in triangle. So when they did an early phase data, this is an Indian paper I have tagged it, early phase. There were two fatal cases of CLS and this death. So after that, they thought that giving venetoclax full dose on the day one can lead to this hemolysis because of its rapid onset of action. So that leads to develop concept of dose ramp up. So you start slow and then gradually increase the dose weekly basis. So that's how the dose ramp up is done. Let's go here. Yeah. So this is the way the dose ramp up is done for venetoclax. Week one, you start with 20. As I said, after you start the drug, 8 hours after that, you check hemolysis. And then next will be after 24 hours, right? After a week, you increase to 50, then 100, then 200, then 400. So you take 5 weeks to reach to the maximum or the adequate therapeutic level. So that's how the concept of dose ramp up comes in. And each time you increase the dose once in a week, you have to admit the patient, hydrate. So think about a drug which is oral, but you have to admit one day, give hydration, give anti-TLS, and then monitor and then discharge. Right? It's not IV drug, it's oral drug, such an effective drug. So how do you decide which patient you want to admit, which you want to manage on OPD basis? That depends on the burden of the disease. If the disease burden is pretty high lymphocyte count, bulky nodes, they have high risk of hemolysis, you start hydration one day before, give anti-TLS, monitor. If the risk of TLS is low, you can manage the OPD basis. Okay? We have patients where we have admitted when you first time you are given, unless there is a patient with hemolysis, right? So that's happened. So that's why important when you give venetoclax, monitor the hemolysis after 8 hours and then after 24 hours. Okay. So this is the dose ramp up. Now there are certain combinations of venetoclax that we use. So if we have, so typically what happens is that how people combine with venetoclax is based on this principle. So typically what happens is that when you combine venetoclax to obinutuzumab, you give first obinutuzumab. After day 22, you start your venetoclax. That means what you want before giving venetoclax is that you want a good disease control so that you mitigate that hemolysis. Typically, when they combine with the ibrutinib, they give for 3 months ibrutinib so that the disease is well controlled. Now start venetoclax so that the risk of CLS is less. Similarly, for obinutuzumab, we start with obinutuzumab. It will bring down the lymphocyte count, it will bring down the node size, and then you start venetoclax, that ramp up. So that kind of mitigates to the CLS to the minimum. The third drug is obinutuzumab. Obinutuzumab is a second generation of rituximab. Important. The only important toxicity that you have to remember is infusion reactions. I have given this data from obinutuzumab, chlorambucil, that paper, and this is the comparison of rituximab and obinutuzumab. All of you might have witnessed the rituximab infusion reactions in the world many times. You get called and to see those patients. But if you just compare the grade 3, grade 4 is 20% on day one. So that's why the obinutuzumab dosing is different from rituximab. Obinutuzumab, you give it 100 milligram dose on day one, and the rest 900 give day 2, right? In spite of that, also you see infusion reaction. So that's why, and that typically is in the first cycle under day one. So that's why these patients need admission in the first cycle and particularly meticulous monitoring for infusion reaction. Now, finally, I'm not going to discuss about CLL. We'll discuss when we will take the class of treatment part. But this is the last slide of my lecture. So just as I said, when you think about CLL and treatment, we have to look for the IGBH mutation and TP53, right? The relevance is there in terms of your prognostication and treatment decision. This is the latest BSS guideline from the NICE. This is the NICE recommendation. And you see that if it is TP53 intact, IGBH mutated, you have data from CLL8 study, MD Anderson group that FCR is better. We'll discuss that. And we have obinutuzumab. But once the TP53 is disrupted, it is mutated or 17p deleted, it is always a novel therapy. Chemotherapy either is not effective, or I would say otherwise it is harmful, because what happens is that when you give chemotherapy in a CLL, it will select the resistant clones always, right? So what happens, you have a TP53 clone, the patient is not affordable for novel therapies. You give chemotherapy, to select those TP53 clones, and the disease course becomes rapid now, right? So you may end up doing harm to the patient rather than giving, thinking that I'm giving some benefit. So that's how it is. So TP53 is such an important tool in the CLL management. So that's it. So if I have to just conclude that you remember, most of your patients will present to you incidentally. CLPDs is a broad group. We have many different cells. Learn how to interpret the flow. I have given you some flow charts. Go back and read about that. Why I know this reading will help you if you do it today, and you have you can remember for your life. So that's what it is. Make your way how to remember. And typically, IgG mutation is important, both prognostic and predictive. Now, novel agents have replaced almost chemotherapy, still using some in patients, but as I said, in future is that it will going to replace completely in CLL. So you have to learn how to manage the toxicity of these agents, and it will come back to you. Because if it may be generic now, maybe you get venetoclax generic in some few down the line. So you have to understand how these drugs act, their side effects, and how to manage that. With that, I think I will take into this. So the dose is 420 mg, so it comes in 140 tablets, so 3 tablets per day. So the cost has come down to now 12,000 per month. So the original cost was 1.8 lakhs. Now after that, when generic came, it became 24,000. Now it is 12,000. So I think it is pretty cheap now. 12,000 per month ibrutinib is something which we never thought. So that's why I stress all of you that you should know molecular is better now, because now the cost of 6 cycles of BR also is it is more than 1 lakh at least, up to 1 lakh. So we have to give the options of people need those who have those molecular and those who can afford all this. It's a continuous therapy.
So reversible bleed fatal complication, even after stopping everything. Is it not only reversible elimination of TEC and the
So yeah, so what happens is that the basic physiology pathophysiology start with that, right? So but there will be an insert, right? For atrial fibrillation, it is not always a drug. So typically you don't see that in a patient who has no other complaints. So somebody is 60 years having gastric dysfunction, obese. So they have also already have a risk factor to develop atrial fibrillation, right? They are just waiting for that insult to happen. So you give TEC inhibition leads to PK pathway effect, and that leads to that heightened sensitivity to develop atrial fibrillation. So that's why it doesn't revert, because you have the risk factor always. If it is purely because of drug, maybe if you stop it and probably drug reverted, right? That's what the general thinking. But why this thinking that even after stopping it doesn't revert? Because they already have the risk factor. They only have that you can't change, right? You can't change the gastric dysfunction of the patient. You can't change, the obesity. You can't change all those cardiac risk factors. So just stopping the drug may not revert. So you have to deal with it and live with it. That's what the cardiologists do in our
reversible, like once it sets.
Yeah, so there are certain situations which is reversible if it is purely because of the insult. But mostly in those patients who are elderly, once they develop, it is usually now you have to go back to kind of rate control. You don't think about it. That's what we send to cardiologists, that they evaluate whether there is any hope for rhythm control. That they will decide. So if I get a patient with atrial fibrillation, I cannot decide that whether the rhythm control will be good for him. So that's why I'll take the help of cardiologist. So cardiologist will decide that no, this patient already this is not going to help rhythm control. We'll just put him in beta blocker, and it will be like this only. And in cardiology studies also, there are randomized studies between rhythm and rate control. There's no difference in overall mortality and overall risk. So that's what most of the cardiologists end up doing, giving beta blocker. I hardly seen. So if somebody is say 30, 40 year, no risk factor, new onset atrial fibrillation, and probably that is one person where probably rhythm control will be done, and they will do it, but typically giving other drugs like but not to a 60-year-old having risk factors. Usually they end up giving only risk.
Is playing EF with contraindication. Patient having already EF.
So if the baseline EF is low, definitely it is a related contraindication, because once there is an atrial fibrillation, definitely. So if the EF is definitely low, preference is more towards benefit. So I don't think there is any cutoff man.
Somebody has an underlying cardiac function, not only just the problem is of sudden cardiac death. So there's quite a high number of sudden cardiac deaths in this group of patients who receive it. They have an underlying, significant cardiac dysfunction, no cutoff, but if there is underlying coronary artery disease, you have to be very, very careful using this. And people now are moving towards other agents in that situation rather than trying to give it.
this question comes to any for drugs for anti-inflammatory, sunitinib or whether given 40% accelerator or not.
So the challenge for most of the diseases is going to be what's the duration of therapy or something. Here in CLL, you can start every or and very long term, what your expected side effects are outweighing the benefits, and in that case, you will have to take it twice before using. So there is a platinum accountability has relatively lower NCD as compared to or otherwise plan for limited black scale.
And sir, one question, sir. Suppose the patient is getting input from the other side, telling from the other side. The patient is on input, most